Thank you, Graham, and thank you, Basim, for inviting me here today. So I'm going to be talking about recognition management of spondyloarthropathies in the MSK setting. And I'll just start by saying what I mean by spondyloarthropathies. It's an inflammatory arthritis, it's not rheumatoid arthritis, and there is a flavour of back inflammation with all of these conditions. Start with that. Okay. In my role as a rheumatologist, every week I do a musculoskeletal clinic, I do a dedicated psoriatic arthritis clinic, and I do a lower limb stroke foot clinic. And it's very interesting because spondyloarthropathies can present to me in any one of those clinics. So I'm going to be covering all of these, and I'm going to do it through case studies, which I hope to be interactive. So I will be asking questions, and if I don't get any replies, I'll be picking on people. So here are my disclosures. Now you see them, no you don't. Okay, and I'm going to go straight into Mr. G. So, 32-year-old Caucasian male presenting with back pain. He's on Ibuprofen. What are you going to do next? It's very common, isn't it? Well, I won't ask too many questions at this stage, but we're all aware that NICE guidance came out last year for back pain plus or minus sciatica. And, you know, what NICE says, so it will say, you know, first 32-year-old bloke, back pain, we go down this pathway here, we assess and risk stratify. Okay. However, before you get to that, there is this little box here, exclusions. So we need to determine from this guy, 32, back pain, common, is this an exclusion criteria that doesn't fall within the NICE pathway, or is actually this is a mechanical back problem that we should be assessing? So what sort of questions would I ask as a rheumatologist about this guy? What do I want to know about this guy, which may alert me to the fact that this just isn't mechanical back pain? Yeah, morning stiffness.
Night pain?
Yeah, night pain, in particular the second half of the night. Okay, so if you sort of wake up in the early hours of the morning with back pain, that's highly suggestive of an inflammatory back problem. Any other questions I might ask? Yeah, does it improve by exercise? So I will ask about weight loss because that's one of my red flag questions. NICE don't talk about red flags, but I quite like them because I find it quite quick and easy to ask those questions when I'm seeing someone with back pain. And I accept that I will see a small, you know, a certain cohort of patients with back pain that will have probably made it past you guys. So yeah, what are particularly about inflammation?
Anti-inflammatory.
Yeah, the response to anti-inflammatory drugs, you know, so, oh yeah, really help with ibuprofen. Paracetamol's rubbish, doesn't do anything. Cocodamol, yeah, nothing. But, oh yeah, that naproxen, really good. So these are, I've summarized sort of the red flag questions. Okay, and these are quick and simple questions you can ask. You know, weight loss, if it's an elderly patient, is there risk factors for osteoporosis? Is there, you know, am I thinking inflammatory back pain, as you've all said, worse first thing in the morning, stiff for more than half an hour, relieved by anti-inflammatories, relieved by exercise, although there's a caveat to that. We always say relieved by exercise, but if you've got rip-roaring sacroiliitis with really deep-seated buttock pain, that doesn't get better with exercise, that just hurts, okay? And then trauma, etc. So these are the red flags which will point me towards the exclusion criteria from NICE. And then obviously we've got your yellow flags, which if they are a NICE patient, would alert me to, you know, is this a potential problem which could lead to chronic back pain? So this chap, Mr. G, I find out that actually ibuprofen's great, really helps him, okay? He is stiff first thing in the morning, more than 30 minutes. He really, you know, and he normally gets up for a swim. So you will see these in your athletic population because actually a lot of these guys tend to be very active and very sporty because actually it really helps them. And he's had anterior uveitis. I was a red eye. Have you had a red eye that necessitated you going to a doctor? And 4 years ago, he was treated for an Achilles tendinopathy. I find the Achilles tendon really interesting. I know this is bread and butter for you guys, but I always think muscular tendinous junction, prone to rupture. Mid-substance tendon, prone to tendinopathy. And I won't get into the debate about degenerative inflammatory here. Insertional tendon, again, tendinopathy, very similar histological findings, but a bit more prone to impingement. And then the thing that excites me, gets me out of bed in the morning, is this insertion, or the enthesitis, where the tendon inserts into the bone. Because that, when it becomes inflamed, should alert you to the fact that this is more than just a sort of tendinopathy. This is an enthesitis which we see in our spondyloarthropathies, and it's classic. Okay, so what investigations are you going to do with this guy? So you've seen him. At this stage, what would you contemplate doing?